Good afternoon, everybody. This is the monthly Public Health PBRN virtual meeting, and we'll get started in just a few minutes, give people a little bit more time to dial in and log on. Again, good afternoon, everybody. This is the Public Health PBRN monthly virtual meeting for February 2012. We'll be getting started in just another minute or two. Give folks a little bit more time to get logged on. Well, again, good afternoon, everybody, and welcome to the February edition of the Public Health PBRN monthly webinar. We've got another great agenda lined up, I think, for today, and look forward to the discussion. For the first part of our meeting, as we normally do, we allocate that part of the agenda to hearing some updates on research in progress from one of our Public Health PBRN colleagues. And this month, our Missouri affiliate Public Health PBRN has agreed to take the reins and share with us some work that they have underway. So we're very pleased today to hear from a couple of the leaders within the Missouri Public Health PBRN about some work underway there, looking at quality improvements activities in public health settings in Missouri, and patterns and drivers of those activities. It looks like we have both of our speakers logged on and queued up and ready today. We're going to hear, I believe we're going to hear first from Dr. Beverly Triana Treme, who is with the Public Health Consulting Group there in Missouri and an active leader in the network. And we'll also hear from Dr. Katie, and Katie, I apologize, I always get your pronunciation of your last name correct.
It's okay. Stamatakis.
Stamatakis, thank you. And Katie is a faculty member at the Washington University in St. Louis there, and an active public health services and systems researcher, and also a collaborator and colleague in Missouri Public Health PBRN. So I think what I'm going to try to do, and Triana, you're going to speak first, is that right?
Yes, sir. Yes.
I'm sorry, Beverly. I'm getting all kind of names wrong today. What I'm going to do is try to transfer control of the session over to you.
Sure.
And see if you can take control of the slides, and if you have any trouble, just let us know.
Okay. I'll figure out what to do. Do I do anything right now, or is it going to give it to me?
You should have it. You should have it. If you can see, see if you're able to advance slides now.
Let's see here. I'm trying to advance the slide. Oh, there we go. Okay. I suddenly don't know how to use PowerPoint. That's good. Okay. All right. So may I go ahead and get started?
Please do. Thank you.
Okay. All right. Well, thank you, Dr. Mays. I appreciate you inviting us to do this, and it's been a wonderful year doing our research on the quality improvement philosophy for rural local health departments in Missouri. And as you see on the main slide here, is our research team, myself and Dr. Stamatakis, Kathleen, and Kathleen Wojciechowski, and Janet Kennedisi, and Emily Martin, and Farah Naz. Emily and Farah were two research assistants who have their MPH and look for them to do bright things in the future. They really helped us out a lot on this. So let's go ahead and get started on the next slide here. Just a little bit about the Missouri Institute for Community Health. We are based in collaboration, and our purpose is to convene and facilitate conversations about the future of the public's health and a community-based health system. And we feel the community is where it is, and getting people in different sectors together to identify how the public health can be improved is the way it needs to be done. So that's really our role here. The purpose of our research was to complete our first research project of the Missouri Public Health Practice-Based Network, and the second was we designed an interview protocol using the 9 elements of quality improvement. And I do have to say, when we found this resource with a conference that was done, I believe, Dr. Mays, you can correct me, it was 2009?
I think that's right.
Okay, okay. It was called Adapting Quality Improvement to Public Health, and that was led by Dr. Mays, and they researched all of the different areas of quality improvement in other sectors, law enforcement, fire, and other areas, and what quality improvement was and how we could translate that into the public health field. This resource, based on that conference, came across Kathleen, Janet, and my desk, and we saw it, we thought, okay, we could use this as a starting off point for developing an instrument that could certainly, we hope, in the future be used for technical assistance. So you'll learn more about that instrument in a little bit. So we conducted key informant interviews in a subsample of 8 accredited health departments in the Missouri system and 8 non-accredited local health departments to address with whom and how QI is approached. Our definition of quality improvement is defined as an environment of critical examination, reflection, that a local health department applies to its programs, policies, and practices, which permeate throughout the organization and programs through time. As I work with local health departments and other organizations on QI and evaluation, I liken QI to those little rubber band balls that you see. If you have an organization that has a culturated QI, it will look like that to them. It will be really, stranded across time through programs, through policies, and through practices. It won't be real one-shot throughout. So that's kind of what we're looking for here for public health to adopt here. Okay. Research questions were what populations are targeted with QI? How is it used? I mean, do they use it for capacity building? Do they use it to help coworkers understand programs better with stakeholders in personal change? I'm a huge advocate that before we can get public health to change, we've got to get those leading public health to realize how quality impacts their daily lives, personally and professionally. And our second question was, what public health problems are targeted with QI? These are two burning questions for me, and I know our research team is, could be the basis for how we approach technical assistance with QI. And what do they do to solve it? Is it a communication problem? Is it a human resource problem? Improving leadership and so forth. So there are a plethora of different ways here we could approach this. And Dr. May certainly recognizes this, I'm sure. These are the 9 elements that came from his work called a quality improvement philosophy. And we kind of coined that term, quality improvement philosophy, QIP, but these are the 9 elements that Dr. Mays and other leaders created or gave us in a collective article where all that research was shown. It's a clear shared vision. You have strong and supportive leadership. You have measurable goals. You're grounded in what you're going to do and how you're going to do it, and you do it with effective interventions. You pay attention to external influences, policy, the taxes, funding, all of those different things. You have data resources. You make decisions based on data and not on what you think you should do or what the next county is doing. You have experience using data, and you provide motivation and incentives to use QI. And last of all, which probably can circle all of these, is you're transparent with all of your stakeholders, your staff, your funders, people who are in public health on a daily basis. So those are the 9 elements. Keep those in mind as we go forward, and those form the categories for our instrument that you'll be able to download, or we can certainly make available to the group later. So with the emergence of National Accreditation Program, we have used this research as a catalyst to take on a new charge. You might think, okay, well, the national program is coming on. Are we done? No, we don't feel that that's the case. We feel we have more work to do. We want to become a partner with local health departments and understand their day-to-day training needs to make a systematic change for public health infrastructure. And we think that accreditation could serve as that driver and sustainer of quality. Our study process, we reviewed the literature for descriptions for the 9 elements and used feedback from our advisory panel that led us through the year. And for example, when the 9 elements, when we found those, we felt we needed to come up with questions that would form an instrument. For example, what does it mean? How can you measure if an organization is transparent? What actions do they do? What beliefs do they have? How do they become transparent to the outside world? And so we came up with a list of questions within these categories that we hope are, have face validity and content validity there. We ended up with 110 questions, of which 14 were open-ended. And our research assistants, we were very proud of the fact that we brought them in to do the interviews, and then they were listened to and validated by myself and to make sure there were any questions or issues about the interview. We did train them on interviewing techniques and piloted the process with 2 health departments. Okay, so we had the 9 elements of a QIP, Quality Improvement Philosophy, and we decided to break them down to get an understanding of the synergistic relationship between these 9 elements. The project team created Model QIP, so we came up with 3 value sets. Value set is the foundational elements, or a clear shared vision and strong supportive leadership. We felt that, just like a family, you have to have that vision for what you want your children to do, and you have to have leadership in parents. We kind of felt that was the same thing here with the public health family. The value set B are the practical elements, your rich data resources and experience using data in the field. And then our value set C are the directional elements. And these are where you're going to go and how you're going to get there with evidence-based practices. So if you look at our next slide, we put it into a model. And it's really the same thing that I just mentioned. And we have mediating factors of transparency and motivation and incentives that hopefully all of these through time, an organization pays attention to these 9 elements, we hopefully lead to a quality improvement philosophy. Okay, so let's get on with our findings from our qualitative data comparing accredited and non-accredited local health departments. Now keep in mind that even though this is a qualitative study, we do have to pay attention to possibly one, I don't want to call it a flaw because I think public health research, we know that there are limitations, if you will, in the way we can do some research. Did these accredited health departments, did they have some type of characteristic or drive to be quality when they applied? And so therefore, you know, it's which came first, the quality or the accreditation. So do keep that in mind. There's no way you will know for sure. But that's why we feel we can turn this into a technical assistance model because I think even accredited health departments can get to that next level. And they can in turn teach their unaccredited counterparts. So here are some findings that we found. The relationship between the agency and the governing structure. Although some of the non-accredited agencies showed higher level integration between board and the department, the accredited agencies overwhelmingly reported the characteristics that they felt there was a strong relationship between agency and governing structure, that it was more of a synergistic relationship. Problem solved with QI tools. Accredited agencies use QI tools less as a personal professional improvement tool and more in integrated approaches. In other words, they use QI tools in evaluation, in working with stakeholders in the community. They mentioned it with legislators more. It was connected to more funding. So those types of things. They used it more systematically rather than as trying to improve one part of a program or a department. Specific and measurable goals, the accredited agencies, all of the statement categories like goals, written statements, objectives, all of those types of things, all of those categories were overwhelmingly reported as provided by the accredited agencies, except written objectives. So written objectives was the only thing that was pretty much the same between the two groups. But accredited agencies, they had down goal statements, objectives, aims, visions, all of those things much better. Interestingly, on the communication with legislatures, they all communicated with legislators, but accredited agencies tended to do it more systematically. They attended more hearings. They were interviewed by legislators more. They had more contact with them. They went to you know, their capital more rather than emails and letters, more of a two-way street, I would say. One accredited agencies remarked that they have their legislators do ride-alongs with them when they're going out in their county to do their public health work. So kind of an innovative practice in my opinion. When we combined all of the local health departments together, regardless of whether they were accredited or not accredited, we found some interesting findings here. QI requirements in the job descriptions. QI requirements were included in job descriptions in only half of their local health departments. They were included in performance appraisals in more than half. And for other positions, most did not have QI in the job description or did not have QI in the performance appraisal. And, you know, I have a saying when I'm out doing consulting that if you did not document, you did not do. And so it's very, very important that you have to document what you expect your employees to do on the job. And the first way you do that is to put it in their job description or in their performance appraisal. Types of training, very interesting. Kathleen and I had a long discussion about this one, that high frequency of training and courses related to emergency preparedness, event management, and environmental health but low frequencies in courses such as biostatistics, evidence-based decision-making, health systems, and personnel management and policy development. And I think this is something that more as a call to action, and this is probably not anything that surprises anybody, but I think it's very important that we have training that is not related to, you know, public health at the moment, but that will have some long-term, you know, kind of cross-curriculum benefits here. So we can train in emergency preparedness, but can we have training in policy development and, you know, cost accounting, budgeting, and hopefully gain skills that will work across public health issues. Presence in the media. This one here, I think, could can pose a good debate. When should public health be in touch with the media? We had comments that, well, only when we have an emergency or they need to know something. My question back to public health leaders is that sufficient? Should we only have public meetings when there is an emergency that cause the public to think that that's all that we're for, all public health departments are for? And so I think that's something that we could talk about in the future, I think. Okay, so some thoughts in closing. Whoa, this is really large here. I don't know why that is the case here.
Sorry about that. Let's see if it adjusts. There it goes.
Can you guys fix that on your end, or do I have to fix it?
I've never seen anything quite like that. It looks like it's just a problem with that one slide. Maybe you can just talk us through it. I'm sorry, Beverly.
Oh, that's okay. No problem. Let's see. Hold on a second. Now, are you seeing my screen right now?
I'm seeing the slide with very large print on it.
Okay. All right, just a second. Yeah, it wasn't that way when I don't know what happened. It got converted somehow.
Sometimes there are some, conversion issues.
Yeah, that's okay. Okay, is there a possibility of me sharing my screen right now?
Yes, I think you can share your, I think you can do that.
Share my desktop? Could I hit that and see
yes,
if it works?
If you see a button that says that, hit it and see what happens. I think we're getting ready to see your desktop.
Oh, wow. I've never solved a problem that quickly. Okay.
Very good, Beverly. Very good. I'm impressed.
Okay. Yeah, I planned that to show you how good I was at PowerPoint. Okay. All right. So now we have, this was the next slide that was really, really big. So this is the correct size. So some thoughts in closing. What Mitch hopes to do and hopes to engage with other stakeholders and collaborators across the nation is smarter technical assistance. Where does technical assistance need to be? And can technical assistance get at the nitty-gritty of what health departments really need in order to become focused on quality improvement? And what we found in one of the findings for local health departments in Missouri is they were judged on their ability to collect data, to analyze that data, prepare a formal report, and then present the findings. And what we found is that both groups collected and analyzed data. I think we're pretty good at that. But preparing the data, reporting it, making an argument for public health with legislators and other stakeholders was lower for the non-accredited agencies. And so accredited groups more frequently prepared and presented their findings to communities and stakeholders and used more, they synthesized the data more and used statistics and used, rationales and justifications and using that data to support why we should have public health. And so, we want to provide training that would allow them to apply these skills. Any one of these particular skills here, collect, analyze, report, and present, you could have an entire technical assistance training on each one of those. So what we came up with is activities for tailored TA to reach a quality improvement philosophy. So you have the novice stage, the building stage, and the maintenance stage. And so you can just kind of go through these at your own time. And you know, you want to start off with people never having done QI, different activities than those who are already into it. Okay, so QIP instrument as a TA tool, if you're interested in this tool, let me know and I can certainly send it to you. We will make it available on our site. What we're looking at here is the intensity of QI. If you look at the arrow and the time, we want it to go from selecting a QI tool to improve a process all the way up to, it's no longer about QI, but it's a philosophy that permeates its way through the organization as a way we do business. And we feel our QI instrument could be used as a baseline and a periodic assessment. This is just a slide about business with the heart. This is something else that we want to do, just something that comes up that we put in our article that we're going to try to get published based on this QIP research. You know, having business with the heart, we've got to be smart about it, but we also realize that we're in the public health business and we want to do what's best for the public. And the last thing, if you see my little deer here, I was told there was no such thing as I didn't realize there was an albino deer, and I went camping and they said, look out for our albino deer in the woods. So my closing message to you is keep believing there is quality improvement out there. And that's what we got to get our people in our local health departments to believe, that they can achieve that if they want to. It's out there. If you have any questions, don't hesitate to contact me. So that's it for my presentation, and I'll turn it over to Katie.
Thank you, Bev.
I'm going to see if we can.
Okay, I need to unshare, correct?
I think I just unshared you.
Oh, okay.
And I'm going to turn it over, see if I can give control to Katie here. Let's see.
I don't need to do anything, Glenn?
No, I think I can do it. I'm going to.
Okay, all right.
Let's see here. Okay, let me see what I've done. So, Katie, I think I have given you control, so I think you should be able to control slides now.
Okay. Let's see if I flip through the rest of Bev's slides. I should get to mine, right? There we go.
There you go.
Okay. All right. Well, I appreciate having the opportunity to talk to you all today. Thank you. And Glenn, you shouldn't feel bad about the name thing. I think between the four of us collaborators on this project, we have kind of a massive amount of syllables. So
yeah, we do.
This is to follow up on some of the great insights that Bev shared from the more qualitative piece of the study. For this part of the project, we were aiming to find some quantitative evidence of the impact of accreditation on QI using some existing data sources. So here we had to basically sacrifice some of the richness of the data and information on QI in an attempt to quantify some impact. So some of the existing data sources that we used included the Missouri Local Public Health Agency Infrastructure Survey, which had been collected here in Missouri from all of the LHDs over a number of years, pre and post implementation of the voluntary accreditation program. We used some of the NACCHO profile study of local health department data to provide some descriptive characteristics of LHDs in Missouri. And finally, the Missouri Institute for Community Health administrative records on participants in the accreditation program. So before I get started, I'd just like to acknowledge the very important contributions of a number of people to this work, and this includes first and foremost the leadership of Mitch, Kathleen Wojciechowski, and Janet Canavesi. Other members of the Missouri PBRN also contributed to the study design, data collection, and interpretation of results. And these include Ross Brownson at the PRC in St. Louis, Joe Anderson and Sheila Reed in the Center for Local Public Health Services at the State Health Department, Dalen Dutzman at Missouri State, and Linnell Phillips at Mizzou, as we call it here. And I'd also just like to add that Joe Anderson and Sheila Reed deserve special credit for helping us pull the Missouri infrastructure data, which in some cases meant digging through files that were maintained by different people over the years. And where we didn't think the electronic spreadsheets were usable, they had to actually dig up original scanned questionnaires so that we could re-enter the data. So in some ways, even though we're calling this an analysis of existing data sources, we had to almost start from scratch to go back through time and obtain some pre-accreditation data. So briefly, the purpose of this project was to, as I said, assemble available data on indicators of QI and infrastructure from multiple sources, to examine characteristics of LHD structure and context related to accreditation status, and finally to assess whether QI indicators differed or changed over time where longitudinal data were available according to MITCH accreditation status. Oh gosh, we have another exploding slide here. Let's see. Oh no.
I may be able to.
Like all of them.
Are they all exploded? Let's see.
Yeah.
Let me see if I can pull your files up and.
Can you find the slide on your computer, Katie?
Yeah, I've got it. Let me switch over.
I think Glenn's going to try and do it.
Oh, okay.
I'm going to share my desktop now. Is that okay? And I'll just advance slides for you.
Absolutely, sure.
All right, let me.
I don't think I have the PowerPoint skills that Bev has. I don't.
Oh yeah, right.
Okay. Okay. So can you see the slide now?
Yes, thank you.
Right. Okay. Just tell me when you're ready to switch, and I'll switch.
Okay. So this slide is just showing the distribution of local health departments categorized according to accreditation status, and this is as of April 2011. And so you can see that 15% were accredited, about 19% in progress, about 42% had expressed some initial interest but then made no contact for the previous 3 years. 22% had expressed no interest at all, and then there were a handful, 3 that had become accredited but then dropped out of the program. And so this just kind of provides a picture of what the status of local health departments in Missouri look like. Now, for the subsequent analyses that I'll talk about, we actually had to collapse these categories because we just didn't have the numbers to do the comparisons across all these groups. So from here on, the accredited group includes those who eventually dropped out of the program and those that were in progress by 2008, because the last time point for the variables that we looked at were anchored on 2008. So if you see something that looks like discrepancies in some of the numbers of accredited, that's probably why on some of the next slides. Okay, Glenn. Thanks. Okay, so this provides some description of characteristics of Missouri LHDs according to some selected indicators from the NACHO profile study. So in a nutshell, accredited agencies tended to have larger service populations, larger budgets, and more FTEs. So I don't think there were any big surprises there. We didn't find any big differences across jurisdiction type with respect to the urban-rural breakdown, at least in Missouri LHDs. Okay, next. Here we looked at accreditation status and community health assessment and improvement planning. And here you see the percentage of LHDs that participated in these processes, in these activities, was very high across the board. So there were no differences across accredited and non-accredited agencies. And again, this was no surprise. The LHD core contract had a requirement to do community health assessment, so this is probably just reflecting that. Okay, next. Okay, to start getting at the question of whether accreditation had some kind of a benefit that we could document, at least in these data, we looked at accreditation status in relation to our Missouri LHD Infrastructure Survey indicators of QI for 2002 and 2008. So the accreditation program started in 2003. So 2002 provides us with a pre-accreditation baseline, and then 2008 is the most recent post-program data that we could obtain. And so just to mention, while individual years of this survey had some additional data that could be relevant in terms of indicator of QI, we focused on what we could use for the longitudinal pre-post analysis, which somewhat whittled down the number of indicators to those that you see here in column 1. So the numbers shown in the table are percents with frequency in parentheses, and this is giving a picture of what accredited and non-accredited agencies look like with respect to the 2 time points. So if you look at the numbers in the top row in the shaded area for accredited agencies, you can see that in 2002, about 33% reported having very good or cutting-edge capacity for QI. And that percentage looked like it increased slightly over the time period. In non-accredited agencies, only 18% reported high capacity for QI, and that didn't change over time. So this is sort of capturing a little bit of the change analysis, but also pointing out that it's important to first pay attention to the sort of baseline starting point of accredited and non-accredited agencies, which looks like it's pretty different. So the problem we ran into with statistical analyses here was that we had too many small cell sizes to really generate any reliable statistics. But we think that this at least, like I said, gives a picture of accredited agencies starting out at a higher level to begin with. Okay, and the next slide. So finally, then, to take into account the differences in baseline starting point between the 2 groups, we conducted an analysis of change with respect to QI capacity and strategic planning. So here we reformulated the variables a little bit to reflect this change over time. So the change in QI capacity was defined for one group as improving or staying high over that time period, or worsening or staying low. And then for strategic planning, since I didn't talk about it, go through all the numbers in the previous slide, but strategic planning, yes or no, was high across the board, so we didn't think that would be a good distinguishing factor. So here we created an index derived from summarizing across types of participants in the strategic planning process, so staff, governing body, community participants, and how the plan was used to try and capture some measure of comprehensiveness of the process. And so there we split the groups into those that became more comprehensive over time or dropped or became less comprehensive over time. So what we found, if you look at the first 3 columns, you see the frequency and percent of agencies that fell into these categories overall and by accreditation status. And then in the last column, you see the odds ratio for the comparison. So again, here we didn't find any statistically significant differences. But taking into account our sample size issues, there may be some preliminary evidence here that accredited agencies may have been more likely to have some improved QI capacity. The strategic planning measure looked like there was no difference there and had extremely wide confidence intervals. Okay, next slide. So I'll just briefly go over the next couple slides and hopefully leave a little bit of time for discussion if there are any questions. The conclusions we reached for this was that there may be some consistency in accordance with our hypothesis, but the statistical results were weak. So hopefully this could be useful as some preliminary data now that we have some preliminary effect size estimates to maybe do a more formal power and sample size analysis and kind of build the case for a larger study. We found some data gaps. There were missing data and some inconsistencies over time in how data were collected that forced us to drop some potentially useful variables. And I think that's just a reflection of the fact that we were using existing administrative data that wasn't really collected for the purpose of doing this research in the first place. So, you know, it was a case of us trying to sort of use what was there and just dealing with the limitations. We also identified some potential measurement gaps in terms of error in some of the measurements. So I'll just leave that at that. If there's time to discuss that, we could maybe go into that a little bit more. Next slide. And then as far as future directions for this work, we'd like to examine a map of the accreditation status patterns and see if we can see any regional patterns, at least here in Missouri. I think there's some potential for some additional measurement testing work to start getting at some measures of reliability and validity in these measures. I think in terms of doing some more formal psychometric type evaluation, we might need larger sample sizes. But one starting point could be at least to compare across some existing sources. So using some of the questions that were included on both the Missouri Infrastructure Survey and the Multi-State Learning Collaborative instrument that was used to evaluate that program. And then finally, I think Bev went in depth into this area, but some new measures development. I think there are lots of opportunities there for future studies. And I think I'll just leave it at that and ask for any questions.
Fantastic. Thank you so much, Katie and Beverly, for stepping us through this very interesting work. So we're open for questions. Do folks have some questions about what you've heard today about the work underway in the Missouri PBRN? Maybe I would start. Obviously, there are not that many places where you can do this kind of research right now in the U.S. in terms of states that actually have accreditation programs up and running and have some experience with those programs. But yet we do have a national voluntary accreditation program that launched several months ago, and there's obviously a lot of interest in studying the impact of that national initiative over time. Are there some specific lessons, Beverly and Katie, that you learned from your research to date that would lead to some recommendations you might make about how best to study what's happening with the national accreditation program and its impact?
Well, I guess one thing that I would be looking for is trying to establish right now, since as you said that program was so recently launched, trying to really progress some of this work as far as measurement quickly, so that we can get some decent baseline measures now, so that we can try and document some of the impact over time.
Yeah. That's exactly what I was going to say too. Is the accreditation could be seen as an intervention. It really is on the field, and so making sure that there's measures that we can see that all health departments maybe could take, if there was some mechanism that there could be some type of baseline measurement on how they perform in QI and how all of the different measures for accreditation. would be very valuable.
Yeah, definitely. Sort of getting back to the issue that I raised about measurement error, we found some evidence of that in our infrastructure survey data, as far as some indication that people's definition, respondents' definition of what strategic planning even means can vary quite a bit, and maybe has changed over time. As an example, in our data set, we found there was a question in one of the years that I didn't show here because it didn't fit into the sort of longitudinal analysis, but there was a question on yes or no, do you do strategic planning, and then check boxes for what you used it for. And planning was one of the check boxes, but a number of respondents who reported doing strategic planning did not check that it was used for planning. So that seems to indicate that there has to be some caution in how these data are interpreted, and a little bit more work around measures development.
Very good points.
This is Scott Frank in Cleveland at Case Western. Can you hear me?
Absolutely. Go right ahead.
I did have a question about recognizing your sample size limitations. Because there are such large differences in accreditation by health department size, did you make any effort to control for health department size or characteristics? Because one could argue that these differences could be attributable only to health department size and not accreditation.
Yeah, no, I think that's a great question. I did do some adjustment models, and basically they showed that there was still no association. So I didn't show all of those numbers here, but I think with a larger study, it would be really interesting to do some of those multivariable analyses and see what accounts for the differences. And here, since we didn't really have a strong difference to begin with, it wasn't extremely useful, the subsequent results, because they basically showed that there still was no association.
Other questions? We're just following up a bit on the last question. What was the overall kind of pattern in terms of the selection that you found there in terms of the agencies that underwent accreditation versus those that didn't? You obviously found some pretty strong baseline differences. Do you have any insight from those multivariate models or other about kind of what the main differences were between agencies that pursued accreditation versus those that didn't?
Well, I think that some of Bev's qualitative findings kind of give a richer picture of that than the quantitative stuff that I reported. I mean, here I think as far as budgetary capacity and the size of the population served, and there are numerous other indicators that we could pull from the NACHO data that sort of co-vary with those sort of size and budgetary kind of indicators and show differences. I think Bev got at some interesting sort of differences in process that she found in comparing the two groups where she did the more open-ended interviewing.
Yeah, and going back to the size of the health department, in Missouri, I think it's like 60 or 70% of the people are covered by a rural, or maybe even higher than that, rural health department. So you have a lot of these counties that they're rural, they don't have the resources, they don't have the community resources available to them that are, it's kind of like an exponential effect. Everyone's talking about QI. That tends be translated in all the organizations in that county. But you know, in the qualitative side, we did not include St. Louis or Kansas City in our results. But we saw that the accredited agencies, you know, they more than likely understood the process, the impact, and the outcome benefits of doing quality improvement. So.
This is Cleveland again. I actually just wanted a quick observation and probably get Glenn's comment on it, and that is that if you look at the slide that looks at the nature of the agencies that are accredited, there's an interesting pattern that is consistent with a study that you were involved with, Glenn, that showed that sort of the middle-sized health departments were the health departments that had the best results. The smallest and the largest health departments tended to perform less well, and here it appears to be the middle-sized health departments that were most likely to be accredited, and you know, with whether it's size of the jurisdiction or budget or FTEs, I don't know whether that fits with the study that looked at size of the health department compared to performance, but it at least has that appearance of it.
Yeah.
Yeah, that's a very interesting observation. It sure does. So, yeah, again, it perhaps tells us something about, you know, who the early adopters are with regard to accreditation, and obviously begs for more study on some of these issues. So, with that in mind, I think, if you know, look at the work that the group at Missouri has done here, it's really an impressive amount of work that was done. All of this was done, I think, under the QI Quick Strike grant that Missouri received last year. Really a phenomenal job, you know, a mixed method study with this kind of research. Very, very impressive. Do you have? Does your team have some plans for moving forward? Katie, you mentioned, you know, the quantitative work giving you some effect size estimates that perhaps could be used to help design and justify a larger study. Are you contemplating those kind of future directions at this stage?
Definitely, yeah, and I think you brought up the great opportunity that is given to really scale this up across regions and across localities in the United States with the national accreditation program. So definitely looking for opportunities there.
Given the importance that we've identified for doing some baseline measures, do you have anything that shares the actual ways that how you operationalized your measures in your study that might be available for some of the rest of us to try or look at, consider?
I'm assuming that's more of a question for Bev with the longer instrument that she used. For the quantitative piece, these are all publicly available. The infrastructure survey questions are online, and I can share those links, and then the NACHO questions. So, Bev?
Yeah, we can certainly, what I see in the future is using that instrument that's like 11 or 12 pages filled with questions related to those 9 elements, refining that, using it as a baseline, providing technical assistance, you know, year, 2 years down the road, using it again. We can certainly make that available and would welcome engaging in a conversation about, well, what's not on there that should be and what's on there that shouldn't be, because we want to make it as valid as instrument as possible. So certainly send me an email, and I can share that with you.
I'll do that. This is Pat from Wisconsin. Thank you.
Okay, sure. And I would, if you end up using it, you certainly would like to know what you thought about it. And if to me, the purpose of that measurement is to inform about that organization about to go through change and to help direct intervention.
Right. Yeah. Okay. Thank
you. So yeah, I'll look forward to your email.
Okay, I'll follow up.
Sure.
Great question, and it also brings to mind that there are really a number of studies that are underway through the Public Health PBRNs that have developed measures or are using instruments related in some way to looking at QI activities. And so as these studies are now kind of producing results, and it may be time for us to convene maybe a working group of the PBRNs that have been involved in some element of measurement development around QI capacity to look at what we're learning collectively, and again with an eye toward what Katie mentioned earlier, trying to improve our collective measurement abilities so that we've got the ability to collect better baseline measures for tracking the impact of national accreditation movement and other kinds of activities. So that's something maybe we can tee up for further discussion and next steps. Well, again, thank you so much, Katie and Beverly, for taking time to do this and sharing with us some very interesting research underway within your network. And again, it's really impressive what you all have done in a short period of time with a limited amount of resources. And I think what you've done is kind of exemplify one of the major intents of the Quick Strike Research Program is to give you the ability to do some perhaps smaller scale, limited research, but research that has the potential to lead to larger studies and larger larger learnings from this kind of work. So you've certainly done that, and it's very, very impressive.
Len, this is Elaine. I'm sorry to be chiming in late. Could I make a comment?
Sure.
This is Elaine from Connecticut. Thanks to both of the presenters. Really, really interesting studies.
Thank you.
We're going to. I had a question specifically about one finding around the training from your study, Beverly. You had commented about the kinds of training that department staff are receiving, and I think you said something about not, and I don't have the slide in front of me, but there wasn't much emphasis on policy development, accounting, health systems, and so on. Is that correct?
Yes.
And the environmental mandates and the usual emergency kind of training. Right. The reason I bring this up is one of my hats is we have a public health training grant, and we're looking, there's a lot of emphasis now in the public health training centers around the country in supporting quality improvement accreditation. And I just wonder if this is something somehow, we might look at research related to training or data that's coming out that might support training. We're all doing assessments of training needs, but there may be some national training priorities. So it's just a thought.
No, you're right on it because what we train our people in is what they're going to tend to do, and what we put an importance on. So I would like to engage in a discussion about what that means and who we need to notify of this research and how we can kind of make that known to who needs to know it.
Thank you.
Fantastic. Very, very good comments. Well, thank you again, folks. And just a reminder, we did record this session, so if you have colleagues in your networks that weren't able to join us today but might want to view the session and the research by Beverly and Katie, another time we'll have that link up on the website shortly, the PBRN website. So we do need to move on to some of the other items on our agenda for today. We've got about a half an hour left for some of the more mundane administrative discussion points around the Public Health PBRN program. And just to make sure we've got plenty of time, actually I want to next up ask Dr. Scott Frank from the RAFI and the Ohio Public Health PBRN Network to I want to give the platform to him. He has a description of a project that's being started up in the Ohio network that is potentially of relevance to our larger family of networks. So.
Thanks, Glenn. I apologize, somewhat belatedly send Ann a copy of basically a one-page abstract that is looking at these issues. The low battery light just came on my phone. I hope that's not going to limit me here. But the project that we're looking at is related to many of the different efforts to look at how services will be changed with changes in resources in local health departments, and in particular in this case, looking at how health departments will respond regarding the presence of students in their teaching setting. Health departments would be among the first who would get on board for saying that practical experience is of high importance for public health students, but with the increase in the number of students in graduate public health programs, with the increase in the number of undergraduate degrees, with the number of different teaching programs that have sent students to local health departments, I think there's a real possibility of some decreased capacity for teaching in local health departments that we need to get a handle on. It's not just the capacity of the local health departments that we want to explore, though, but also what sorts of students, what disciplines, and what sorts of teaching experiences represent what health departments might think of as value added rather than value drains on the health departments. Can students be used to extend services or to participate in projects that might not otherwise be done? So these are the things that we're trying to look at. It is our plan to distribute this through our Ohio PBRN. We have a pilot survey that's completed. It's been vetted in a number of sources, with a number of sources here in Ohio. But it does occur to us that if we could recruit other PBRNs in the Public Health PBRN network to distribute within their networks as well, it would be a convenient sample, but it would be a national convenient sample looking at the attitudes of local health departments about how teaching may be affected moving forward. So with that short introduction, I'd be happy to, number one, just answer any questions, but number two, if any of you have similar projects that have been going on in your states or nationally, NACCHO asks a few questions about teaching, but this survey that we've developed gets much more into depth and cuts across different disciplines. It's not just public health education, because that's not what the local health departments have to deal with. So I'm going to pause and hope that it's acknowledged that people have actually been hearing what I was saying.
Yes, absolutely, loud and clear. Your phone hasn't given up yet.
Great.
Thank you, Dr. Frank. This is really interesting and really exciting. I think I've seen an earlier version of your instrument, so I can definitely vouch for the fact that this is this is a very interesting project. I think one that's going to yield some very important findings. Are there any quick questions for Dr. Frank about this initiative?
Scott, this is Betty. I came on a little bit late, but you're clearly going to be taking into account nursing schools, because they have a lot of students in local health department settings too, right?
That's exactly right. Not just nursing, but environmental health. Actually, there are high schools that many health departments allow high school students to shadow or participate, junior colleges, undergraduate, graduate public health, public policy. So we have a fairly exhaustive health educators, community health graduate programs. We have a fairly extensive list of possible involvements and hope we've structured the survey so that it's accomplishable. But you know, for many health departments, like our largest health department here in Cuyahoga County, it's not just what students, but how many schools they have contributing. One health department was telling me that they have 6 different colleges that send students to their local health department. So the degree of difficulty, I think we often don't fully understand in academic public health, and this survey, I think, would get a good handle on that from the local health department side of things.
Okay, this is great. I'm sure there'll be a lot of interest.
So my hope is that people who are interested in seeing the survey will ask whoever's interested just to do the survey as if they're answering as a local health department themselves, so they can get a sense of what the survey is. We have not distributed it out into the field yet and are still willing to make some final changes if people have suggestions, but that people can let us know of their interest. We want to be very careful for those who are willing to participate, that we understand what your PBRN is, so that we really have an accurate sense of what the response rate is from the PBRNs in your jurisdictions. So we need to communicate carefully with you so that we can track the number of responses and the response rate from each of the participating PBRNs. And while obviously not all local health departments participate in the PBRNs that are involved, the interesting thing may be that that one would presume that these are the health departments that have been most involved with teaching and academic programs by virtue of their in the PBRNs. So if even they are questioning their involvement, that would be a pretty significant thing.
Very good. Thank you so much, Scott. And so if people want more information or dialogue, you can certainly either contact Dr. Frank directly, or if you'd rather contact us at the PBRN Coordinating Center, we'd be glad to relay your information and contact information to Dr. Frank and his staff at RAFI, the Ohio Public Health PBRN.
Could you say just briefly, how do we expect, I mean, how would we expect to hear from him? What should we be on the alert for, to be looking for?
Well, if I think probably what I'll do is send an email to Glenn and his staff at the National Coordinating Committee and ask him to distribute it to the to all of the PBRNs rather than asking you to give me those email addresses myself. So I'll send that to you, Glenn, and I'll send out an email that includes a link for the pilot instrument and a little questionnaire about level of interest of your PBRN and some of the characteristics of your PBRN that we'll need in order to track the response to the survey.
Thank you.
That sounds great. Fantastic. Well, if we could, our next item on the agenda is an update from the great state of Washington and from Dr. Betty Beckmeyer, who has some updates for us and some news for us about the FAST study, the Public Health Activities and Services Tracking Study.
Well, this is Betty. Mostly, I can give a brief update, but I also have a question I'd like to pose to folks. And and that is that we've been roaring along with some of the data that we have, particularly around expenditure data, around local public health services. We've looked more deeply at service-specific data around WIC. Can everybody hear me okay?
Yes.
Okay.
So.
And we've been working with a select group of states that has recently expanded with some additional funding that we've gotten. We've been focusing in on maternal-child health. We're just starting to get out beyond maternal-child health to some other services, and I have a couple papers that we're working on that we're just about to submit. Now, in all of that, I'd like to throw out that we were interested in looking at doing some study around changes in STI or STD services provided by local health departments. And want to just briefly ask the question if there are PBRNs on the call that think they might be particularly interested in exploring this possibility of being on a FAST-related grant with us in terms of looking at what we'd be doing. We have to flesh out exactly what, and to a degree that would have to do with the participating states. But we'd be looking at something like changes in local health department service delivery around screening and treatment for STIs, and how those changes and variation in practices impact outcomes. We may also look at the distribution of services provided by community health centers, and how that those differences in types of service delivered by different types of providers has impact on STI incidence rates. And ideally, we could segment this out by looking at disparities, racial and ethnic disparities too. So I know that's not a very tight description of exactly what we're thinking, but mostly I throw that out there if there's a couple minutes for discussion, and we can get a sense of if there are states that might be interested in participating with us, or we can get, you guys could email, individuals can email me as a follow-up. Any questions or thoughts?
Betty, this is Elaine in Connecticut. Could you talk a little bit about your motivation for focusing on this?
Well, for one, good question. For one, I know there's been a lot of change to these services in the last few years, in terms of the amount of service delivered and the degree to which some of these health departments have had to close their screening and treatment services around STI altogether. At the same time, we've got other things in the mix, and that is the healthcare reform will more than likely off a lot of these services into community clinics.
Right.
And so there will be a lot of change going on there. In the past, I've looked into this, and really, the literature is really mixed around the degree to which it's better, in particular for certain populations, to receive and get these services by, for example, smaller community clinics that may be more likely, maybe more set in a neighborhood, be more likely to have people that serve in those clinics that are related, similar to the people receiving the services, or services provided by the local health department that is more able to keep up with and is tied into CDC guidelines, expectations around follow-up, et cetera, et cetera. So I think to some degree the jury is out on what is the appropriate place for some of those services, and to the degree that it differs for different kinds of populations. But we can expect to see a lot of change that has occurred in recent years and also going forward.
Are you including HIV/AIDS?
Well, depends. If that's where the data are, then that may be the place to really hone in on. But absolutely, it's not out of the mix necessarily.
Okay, interesting. Thanks, Betty.
Mm-hmm.
Betty, this is Scott Frank. Have you thought about whether you're going to be looking at incidents in these communities as well? I know here in Cuyahoga County we've had an epidemic of several different sexually transmitted diseases over the past 4 years or so. Are you going to look at whether there have been an increase in rates in communities where there's been where services have been interrupted?
Yeah, that would be the idea, for example. It's complicated, certainly, because, you know, you reduce the surveillance provided by local health departments, and you could very well be, you know, in quotes, reducing the incidence to some degree, just because it's not being detected. So it will be complicated in terms of how to do this, but that would be the kind of thing, Scott, that we'd be wanting to detect. Any other thoughts?
Other thoughts or questions for Betty on this? So again, Betty, the action point is that for people, for networks who might be interested in being involved in this effort, you want folks to contact you directly?
Yes, please, as soon as possible, in fact.
Okay.
You know,
All
but
right.
that doesn't mean you're necessarily committing to anything or whatever. I'm eager to know who might be interested, so we can start some discussions around how to frame this.
Yeah. That makes very good sense. Fantastic. Thank you, Betty, for teeing that up. It's a great opportunity, and again, another opportunity for making use of the growing resource that's coming together through the FAST study and the multi-network data repository that is taking shape under your leadership. So, thank you, Betty.
Great, thanks.
So a few other items to touch base on. We did want to check in on some updates on funding opportunities. We know we're in the final stages of processing applications for a couple of funding opportunities that were made available exclusively to the Public Health PBRN community. One of them is the applications that were submitted just before the holidays for the PBRN multi-network study, which we're calling IMPROVE. The multi-network practice and outcome variation study that is designed to really enhance and expand the goals of FAST to bring some resources to bear to networks that are collaborating this activity and give them resources to conduct some expanded data collection and data analysis opportunities for looking at variation in public health service delivery across communities and across networks. So we're entering the final stages of processing those applications. At this stage, I think we expect notifications to go out from the Foundation on March 1. I thought it was February 21. March 1 now? Ann's telling me it's March 1. For those between now and then, some of you may be getting some queries from the Foundation asking for some additional information regarding your proposals, either on the narrative side or the budget side. And so, if you are an applicant, if you're one of the 10 applicants for that opportunity, you may want to watch your email inbox for inquiries, and then we'll stay in touch and announce those funding decisions as soon as we can from the Foundation. We also have a couple of networks that applied for the mentored junior investigator funding opportunity for junior investigators who want to work with PBRNs. And we're also in the final stages of that review and processing of those awards. And do we have an expected notification date for that, Ann?
Hopefully by the end of next week.
By the end of next week. We're hoping that for those of you who applied for the mentored research experience, that we'll have an update for you on those, or information about funding decisions for those. So those decisions are very close at hand. We also again wanted to remind you about the Quick Strike Research Funds opportunity. If you've got an idea for a Quick Strike Research project, let us know, and we'd love to hear from you. There are a couple of proposals that we have in hand now that we're processing, but also always welcome others if you have if your network has ideas for Quick Strike research opportunities, for time-sensitive research opportunities that you can pursue with a little bit of resources and a little bit of time, and a lot of goodwill and expertise on the part of your network. Let us know. And again, we saw a great example of what you can do with a Quick Strike research opportunity from Missouri today, and how you can position those fairly small-scale projects to lead to opportunities for and inform larger-scale projects that can answer more questions with more and better evidence. So keep those in mind. We also wanted to make sure that you all have heard about two additional funding opportunities that have been announced just this week from the Rodwell Johnson Foundation. After much anticipation, the Foundation released the call for proposals for to fund natural experiments in public health services and systems. That announcement was actually released on Valentine's Day, wasn't it? It was on Tuesday. A nice Valentine's Day present, perhaps. So please take a look at that call. We'll be doing a webinar for people who are interested in that opportunity, describing in more detail that opportunity and what the Foundation is looking for. And I don't have the date of that webinar off the top of my head, but I think it's the 28th, maybe the February 28th. But if you look at this call for proposals that's out now, that's available from the RWJ website, you'll see the date of that webinar. Yeah, and we'll also make sure we'll include that in the next newsletter, and to have the links out for that as well.
Glenn, is that the building evidence for decision making?
That is the building evidence for decision making. Yes, as you see, if you will read that, it is all about funding for natural experiments in public health services and systems.
The webinar.
So I think there's a letter of intent and then an application deadline that's later in March sometime. So we'll make sure that we'll send those links out in the next newsletter. But you may want to go ahead and pull it down off of the Foundation website if it's of interest. Also of note, the Foundation's Public Health Law Research Program has issued another funding opportunity announcement this week as well. And so for those of you who are interested in supporting studies that look at the impact of law on public health through your networks, that may be of interest. We've had several of the public health PBRNs already have received funding under that particular mechanism. I know the Colorado network and North Carolina's network at a minimum have been funded with PHLR grants. There may be some others as well that I'm just not on the top of my head right now, but obviously public health PBRNs can be very good settings for studying the impact of law and changes in the legal environment on public health practice and public health outcomes. So those are a few new funding opportunities that are out on the street this week. A couple of quick updates on dissemination opportunities. This has been an incredible 3 or 4 weeks of abstract writing for a lot of us in terms of writing abstracts for the various calls for research presentations at the various public health research and professional meetings that are coming up. And so I really want to say kudos to all of our colleagues out in the public health PBRNs for rallying to take advantage of these various and sundry opportunities. They all have been stacked up on us in the last couple of weeks. You know, with the Keeneland Conference abstracts coming due last month, 2 different rounds of the Academy Health research meeting abstracts and the Academy Health Interest Group abstracts that just went in yesterday, I think. The APHA call for abstracts that played out over the last couple of weeks as well. I know we had a couple of good sessions put together around PBRN research for APHA in various sections and SPIGs, and I know a number of individual abstracts as well went in from the networks. We had the NACCHO annual meeting call for learning sessions, and I know we had a couple of panel proposals that went in to the NACCHO annual meeting framed around public health PBRN studies. So this is really great. I know this is a lot of work and it's all stacked up together, but we're at a stage now where the research that you all are doing is bearing fruit. You all are having findings come out and practice relevant findings and evidence, and these are great opportunities and venues for sharing that. In case you're not exhausted from abstract writing, there is another opportunity that's still out and open, and that's the National Network of Public Health Institutes has an annual meeting every May, I believe it is, down in New Orleans where they're based. Their call for abstracts for presentations at the NNPHI national meeting is now open through, I think, through the first week in March, March 1st. Oh, through March 1st is the deadline of submissions there. For those of you who might want to be a part of that, that's another great meeting. I've certainly been there a few times in the recent past. We certainly have several member institutes, public health institutes, that are part of public health PBRNs around the country, so you might want to take a look at that. We have our, in terms of other dissemination opportunities, we have our special issue of the Journal of Public Health Management and Practice that's moving along. A number of you are planning to submit papers as part of that special issue. Again, the deadline's March 1 for submission on those, and I think we've talked to everybody who's planning to submit at this stage, and you've got our instructions about how to submit. If we haven't heard from you or you've got questions about that journal special issue, please let us know. Shoot us an email to the PBRN account, and we can follow up with you. But I can tell you we don't have any leeway on that March 1 submission deadline with the journal. This is on a kind of a fast track because we want to have the issue ready to come out in time for it to be available at the APHA annual meeting at the end of October. And so because the journal is planning a special kind of release events at APHA, so a great opportunity. We're still rolling along with the theme issue, the cluster of papers that have been submitted for HAPM on PBRN research, and so we hope to have some word back from the journal on that shortly. And these couple of other dissemination opportunities we talked about briefly last time, the podcasts and the new open access rapid cycle journal Frontiers that we'll be releasing in conjunction with the Keeneland conference. Stay tuned for more information about those 2 initiatives. If you've got some research from your network that you think you'd like to disseminate through one or both of these vehicles, you can certainly let us know. But we'll be pushing out more information soon about the podcast opportunity and about this new open access journal, Frontiers and PHSR, shortly. And certainly we'll be talking a lot about these new vehicles when we're together at the Keeneland conference. And just finally, I know we're in the last couple of minutes of our time together. We did want to mention a reminder that the Keeneland conference is coming up, obviously, in a couple of months, and that means our Public Health PBRN grantee meeting is coming up as well, that we hold in conjunction with the Keeneland conference. And just as a reminder, we're planning to meet as the grantee meeting just prior to the main Keeneland conference, as we've done the past 3 or 4 years. And so we'll be meeting on the Monday and Tuesday of that week, all day on the Monday, April 16th, and then half a day on the Tuesday, April 16th, leading up to the start of the Keeneland conference there on midday on Tuesday the 17th. So that's coming up. We do have funding to support travel for up to 2 people from your networks to attend that meeting. We've got a travel memo that will be going out shortly, emailing out to everybody that provides more information about kind of the travel logistics and what you need to do to get registered for the meeting and et cetera, what you need to keep track of to make sure we can get you reimbursed for your travel. But we're obviously very excited about that. We're actively involving in planning the meeting for that. We've heard from a number of you who have ideas about items to put on the agenda for our PBRN grantee meeting, but it's not too late. If you've got a brilliant idea that you'd like for us to find out, see if we can carve out some time during our PBRN grantee meeting for your idea, please let us know, and we'll see what flexibility we have to incorporate that. But our agenda is so far shaping up quite nicely, as is the agenda for the larger Keeneland conference. You're not going to want to miss this year with CDC Director Tom Frieden and Institute of Medicine Director coming in to give keynote presentations. Some great research happening there. A number of you submitted abstracts to present your research at the main Keeneland conference as well. So with that, let me stop and see if there's any last-minute comments from other folks on the call before we wrap up.
Len, this is Elaine again. Just a quick question, and I did miss the last call, I think, so maybe it came up. But relative to the agenda for the grantee meeting,
yes.
Is there going to be an open discussion about that? It sounds like it's really shaping up, and in order to kind of comment, it would be helpful to have, or to add something, it would be helpful to know what's already there. Can you share a draft? Yeah,
well, absolutely, we can share kind of a preliminary draft of the agenda. We're probably nearly positioned to send that out now. We've got a number of things on deck based on opportunities that we know are coming down from the foundation and some suggestions from a number of our PBRN networks. So we can certainly send around a preliminary draft of the grantee meeting agenda in the next couple of weeks and solicit any additional feedback that folks have on that.
Okay, thanks.
Hey, Glenn, this is Bill Livingood. On the Keeneland conference, you submitted a session with a number of us, and I saw some notifications went out, but it wasn't clear to me on what the notification was for, and I was just wondering if you had a notification on that session. So. Good question. I did see that notifications have gone out. I have to confess, I have not read those emails carefully yet, so I don't know the answer to that, Bill, but I will investigate. Great. Let me get back to you on that about the specific session that you're involved in. I have to confess, I've not had a chance to read those carefully yet. Great. And while we're on the phone, you have on the agenda the next webinar on March 15th will be presenting, and it very much relates to a lot of what was presented today, including psychometric testing of some instruments related to quality improvement, and particularly the use of looking at quality improvement across multi-jurisdictional institutions or entities, and so we'll be doing that next month. So just fantastic. Thank you so much. And that also reminds me, I saw that you're giving you're part of a special webinar that's happening with NIH sponsorship on system science methodologies in health that's coming up, I think, on February 21. So that's going to be in our next newsletter for folks who might be interested and want to see another venue and more of your work, Bill, with in public health. Thank you very much. So with that, I think we're probably at time to sign off. So thank you all for participating. If there's any follow-up conversations that need to take place based on stuff we talked about today, keep your cards and letters coming. Send us an email or give us a call, and we'll be glad to work with you. Thanks so much, everybody. Thank you, Glenn. Bye.